Good evening, everyone. We would love to welcome you to our webinar today, which is in collaboration with the Saudi Patient Safety Center, the SPSC. This is the national authority that's dedicated to advancing patient safety across all the healthcare sectors in Saudi Arabia. Sorry about that. So the center's mission is to foster a culture of safety, minimize preventable harm, and ensure the provision of safer healthcare services through the evidence-based policies, education, and innovation. My name is Dr. Samar Zainal. I'm a neonatal intensive care consultant at Prince Sultan Military Medical City in Riyadh, and I have the pleasure of serving you as the moderator for today's session. It is my greatest honor to introduce our distinguished speaker, Professor Badr Sabeh, who will be presenting on the topic today, A Safer Tomorrow Begins Today, Mobilizing Efforts for Pediatric and Newborn Safety. Professor Sabeh is a graduate of the College of Medicine at King Saud University, Riyadh, class of 1987. He is a highly respected certified neonatologist from King Khalid University's hospital, and he has obtained his certification in the neonatal follow-up for high-risk newborns in 1999 from the University of Manitoba, Canada. His work focuses really on the early detection of neurodevelopmental delays, timely intervention, and preventing disabilities. In 2000, he established one of the first neonatal follow-up programs in Saudi Arabia, which has continues to lead to this today. It is with a great pleasure, so let us now welcome Professor Badr Sabeh to begin his presentation. And please note that we will be reserving some time at the end of this presentation to answer all your questions, so kindly post them in the chat. Professor Sabeh.
Okay, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Samar, for your nice introduction. I would like to thank the organizing committee for inviting me to share with you the topic of tonight, which is A Safer Tomorrow Begins Today. These are the four objectives that I will try to cover within the coming hour or so. As a neonatologist, I will elaborate on the importance of antenatal care, on the well-being of the fetus and bonding between the mother and her baby. And as a certified baby-friendly hospital initiative lecturer, I will cover briefly about the baby-friendly hospital initiative, which includes the third objective, key messages we give to the mothers to help them in what is called weaning or introduction of solids. And as part of my subspecialty dealing with neonatal follow-up clinics to prevent future handicap, I will talk about care and follow-up of preterm and sick newborns. So let us start with the importance of antenatal care, which is to promote the well-being of the fetus and to monitor the newborn mother bonding. These are the major components of antenatal care, which include regular check-ups, scheduled visits throughout pregnancy to monitor the maternal and fetal well-being. Typically, the mother will have 8 to 12 visits through pregnancy with increased frequency in the third trimester. The obstetrician might ask for blood tests, ultrasounds, and other diagnostic procedures to detect potential complications and monitor fetal development. There is also risk assessment to identify potential health risk to the mother and baby, allowing early intervention and specialized care if needed. The last one is also very important, which is health education to guide on nutrition, exercise, and preparation for childbirth and parenting to promote optimal outcome for the mother and the newborn. Just briefly, I will tell you about the stages of fetal development. We have 3 stages: germinal stage from 0 to 2 weeks, in which fertilization happens, and it ends with implantation of the blastocyte in the uterus, uterine wall. Cell division begins, and the zygote travels to the uterus. The second stage is called embryonic stage from week 3 to 8, during which major organs are formed. And the third final stage is called fetal stage from 9 weeks till birth. Organs mature and grow. The fetus begins to move. Facial features develop, and sex is identified, male or female. Majority of growth in weight and length occurs during this fetal stage. So the antenatal care and fetal well-being is aiming at early detection of complications with regular monitor, which can help and allow the healthcare providers to identify and address potential issues like, for example, gestational diabetes, preeclampsia, fetal growth restriction or IUGR, before they become serious. Ultrasound and physical examination track fetal growth patterns, ensuring development is progressing normally throughout each trimester. There is regular heart rate monitor and movement assessment provide crucial information about the baby's well-being and oxygen supply. Monitoring position, size, and health status helps healthcare provider preparing for delivery, which will lead to reduction of the risk during childbirth. I like to ask this question all the time when I'm doing round in ICU or giving lectures or symposia regarding bonding between the mother and her baby. When is the best time to start bonding? These are the commonest answers I receive. A, immediately after birth. B, during pregnancy. C, in the first day after delivery when mother is relaxed. Most of the doctors and nurses will give me immediately after birth. But my question is the best time. Practically, the earliest possible introduction of bonding is the best. So from these three choices, clinically and practically, we are following antenatal or during pregnancy, but the best academically is none of the above. The best time when the mother decided to get pregnant, which means before conception. The logic behind that, suppose the mother is diabetic, not controlled, obese, alcoholic, smoker, having very bad habits. If she got pregnant, then the risk of having abnormality in the fetus and the mother as well is high. But if she was counseled before conception and the counselor, which is usually the obstetrician, advised her to reduce her weight, change her lifestyle, stop smoking, control your diabetes, then she can get pregnant. In that way, we will assure that the fetus will be as normal as possible, as well as the mother. Plus, the mother, when she stop or avoid what she liked to do before and she changed her lifestyle for this fetus, as if she's talking to the fetus in her uterus, telling him or her that I changed my lifestyle, I stopped everything because of you. She will be attached to him and she will be very, very keen to come to antenatal visits, look at the ultrasound, and ask about the well-being of her baby until delivery. So this is the best time to have the best bonding. But as I said, practically and clinically, most of the centers are doing prenatal bonding, which is antenatal, which is the emotional connection that develops between a mother and her unborn baby during pregnancy. This relationship begins to form long before delivery. Research shows that maternal fetal bonding influences brain development and sets the foundation for both natal attachment and emotional security. Bonding activities in the form of talking to the baby, gentle belly touching, responding to kicks, playing music, visualizing interactions, all contribute to prenatal bonding. So higher maternal fetal bonding scores are associated with higher postnatal maternal infant bonding, serving as a protective factor even in cases of unplanned pregnancy. Antenatal care provides multiple opportunities to strengthen the bond between the mother and baby before birth, which has lasting positive effect after delivery. Seeing the baby during ultrasound examination creates a visual connection between the mother and her fetus that makes pregnancy more enjoyable, enhancing maternal-fetal bonding. Healthcare providers teach mothers to recognize and respond to fetal movement, creating a two-way communication that strengthens the emotional connection. Classes and counseling help parents understand fetal development and prepare for parenthood, fostering attachment even before birth. So these are the major long-term benefits of mother and baby from bonding. It enhances child development. It makes a stronger mother-child bond, reduce the risk of postpartum depression, and better parenting confidence. I think most of all of us know that there is something called kangaroo care, which is a standard routine care in all in ICUs in developing countries, in developed countries, in our country also as well. In all the NICU centers, nurses and doctors, they know about kangaroo care. Even parents, they start to know this terminology, kangaroo care, which, as you know, is named after kangaroo, the animal kangaroo, and it is a skin-to-skin contact, and it's the best way to have bonding inside the ICU between the mother and her baby. Human being knows this skin-to-skin contact thousands of years ago. It is not something new. It was known in Asia and in Africa, in which the mothers work in the field. So after delivery, the mother carries her baby in her back or in her chest between the breast and wrap the baby and goes to work. This is skin-to-skin contact, but medically, it was first introduced to NICU in 1987, if I remember well, by Professor Edgar Ray in Bogota, Colombia, because they didn't have any NICU incubators or any modern technology, and infant or the mortality rate was 80%. So after adopting this technique, the survival rate became 80% instead of mortality rate. So his practice spread after that to America, then to Canada, then to Europe, and then all over the world. So everybody knows what is kangaroo care as a modern and routine care for the newborn inside the ICU. Now, we come to the baby-friendly hospital initiative, which is to promote exclusive breastfeeding starting from hospitals. It was started by a royal order by the late King Fahd in some hospitals in the Ministry of Health. And then at the time of the late King Abdullah, it's becoming more spread to the most of the hospitals of Ministry of Health until currently it is becoming a mandatory program for all hospitals, private and governmental hospital, to have what is called baby-friendly hospital initiative, which includes 10 steps. I will not go in details, but I think most of you maybe know about it, especially those centers who are already certified as baby-friendly hospital. The first step is to have a breastfeeding policy. Staff receive breastfeeding training. Staff means anybody, nurse, doctor, administration, even security who are working with mother or babies, they should have this training. Breastfeeding education during pregnancy is given to the mothers, but it should be done by a certified nurse or doctor. Skin-to-skin contact immediately after birth. Help mother to start and maintain breastfeeding. Step number 6, breast milk is all babies need. Number 7, keep mothers and babies together, which is called rooming in. Number 8, let the baby lead the feeding. So baby-led feeding. He's the one to decide when to feed and how frequent. Number 9, no teats or dummies for breastfeeding babies. The last one, number 10, is breastfeeding support following discharge from the hospital. It is our duty in the Baby-Friendly Hospital Initiative to support the mothers regarding what is called weaning or introduction of solids. So we don't leave her until her breastfeeding is the only thing you need. Many mothers I received in my clinics, and I'm sure most of you, they are complaining that when they start introduction of solids, the babies were not tolerating. They failed to wean them from the breast or from milk in general. So that's why in this program, we give 10 messages, 10 key messages in infants feeding to ensure to overcome this problem and help and support the mothers. Because the period of from pregnancy to the first 2 years of life is very important period of rapid growth and development for children. Feeding the mother is very important during pregnancy because that will ensure baby grows and develop well. Breast milk and other healthy food are the building blocks needed to grow and develop into strong, healthy, and productive children and later adults. So these coming 10 messages are our recipe for ensuring our children have a good start in life with a solid foundation to grow and develop well. Previous all the studies, they were looking at the causes of death in children under the age of 5. This is issued by WHO and WHA, which is World Health Assembly. They found that maternal and child undernourishment contributes to 35% of death under the age of 5 years. So that initiates and mandates and make it stronger for us to have baby-friendly hospitals, to have introduction and education to the mother, especially in the poor countries. So the first message, breastfeeding for 2 years of age or longer helps a child to develop and grow strong and healthy. What is the definition of exclusive breastfeeding, which is the main aim of the Baby-Friendly Hospital Initiative, is to have or allow the baby to have only breast milk for the first 6 months of life, no other foods or drinks, even water. So only breast milk for the first 6 months. Any mother who does this, she's assigned as a successful exclusive breastfeeding. From 6 to 12 months, still breastfeeding contributes to provide 50% or more of the child's nutritional needs. From 12 to 24 months, almost a third of the nutritional needs of the children or the child contributed by the breast milk. So the breast milk continues to be the best and mandatory for the first 24 months of life, and specifically in the first 6 months. Breastfeeding also protects children against many illnesses, contains fat needed for brain development, provides closeness and bonding between the mother and her baby, protects the mother's health. The second message we give to the mothers, starting other food in addition to breast milk at 6 completed months helps child to grow. This is called complementary food. Very important to tell the mothers in order to avoid failure is to introduce new foods one at a time. And I underline this because this is very important. This is the main cause of failure of weaning. Mothers are introducing 1, 2, 3 types of food at the same time, which is not advised. Only one at a time for 4 to 5 days before starting another food. So if your child has a reaction or allergy, you will know which food caused it and avoid giving it again. Okay? But if you give 3 foods or 4 at the same time and the baby developed allergy, you don't know which one of them is causing this. So the mother will avoid all the food she gave to the child, and that's the reason for failure. Start with food such as boiled mashed pumpkins, soft cooked strained dal. Dal is a type of lentil اللي هو العدس. Porridge اللي هي العصيدة, and rice and stable crop. These food must be nutritious and given in enough amount to the child. It is best not to add salt and sugar to their food. This is another mistake done by mothers. He doesn't like pumpkins, he doesn't like rice or potatoes. The mother will add salt. Some of them will add sugar to the food so the baby can eat it. This is not healthy, not advised, because we don't want the child to taste the salt or the sugar. I want him to taste the original nutritious food. If the mother keep doing this, so what happened? The child, if he grows, he will not eat anything which is not salty or not sweet. Then they will go to the fast food to put ketchup on the food and salt and so on. So please advise the mother not to add salt or sugar to the babies. The third message, foods that are thick enough to stay in the spoon give more energy to the child. At 6 completed months, it has to be completed. That's why they put it in days, also 180 days. Babies need to learn to eat thick porridge, pureed and mashed food, because these provide the child with extra energy compared with liquid or thin food. At this stage, the baby's digestive system, which is 6 months of age, is mature enough to begin to digest a range of food. So don't give before 6 months. See the difference? This is the thick food and this is the watery food. Start small with teaspoon of food and gradually increase amount as the child accepts the new taste. The stomach of a young child is small. At 8 months of age, it can hold about 200 ml, which is 3/4 of a cup at one time. So don't give too much amount, but with time, you can increase gradually. The fourth message, animal source food are especially good for children to help them grow strong and lively. Animal source of food such as chicken, lamb, fish, and beef include liver, yogurt, cheese, eggs, and milk are rich in many nutrients, including protein, iron, and help the baby to grow. Foods from animal source should be eaten daily in as many meals as possible. Milk, fish, and eggs are excellent for children because they are high in protein and easy to eat. Beans, peas, including dal, this is dal, are good source of protein and iron. They concentrated in WHO on dal اللي هو العدس هذا الأصفر because they said that it is equivalent to meat. Can you imagine that? It is like meat. So it is if meat is not available or fish in the poor countries or the family cannot afford it, the best choice is dal, which is comparable to meat, as if you are giving meat to the child. Nuts and seeds are good source also of protein and fat. But you need to mash the beans and peas well before adding to baby's food. They should not be eaten as solid. Message number 6, dark green leaves and yellow colored fruits are vegetables help to a child to have healthy eyes and fewer infection. There's a variety of vegetables and fruits in the child diet, help him to meet many nutrient needs. Add well-cooked, strained or mashed vegetables, such as green beans and peas, pumpkins or carrots to the soft mashed porridge. that are first food for baby between 6 to 7 months. Local fruits such as banana, mango, mandarin, oranges, and so on contribute to vitamin A and vitamin C to the child diet. Aim to include some vegetables in baby's meals daily. So these are a variety of food. Fruits make a good snack food for babies. So for snack, you can use fruits and vegetables and try to search for yellow or green fruits and vegetables. A growing child needs 2 to 4 meals per day, plus 1 to 2 snacks if hungry. Give a variety of food. This is message number 7. It is important for the child to eat a mixture of foods at meal time. Aim to include foods from the 3 food groups in the meals. Each day, give a dark green vegetables or yellow colored fruit or vegetables and an animal source food in addition to stable foods. Since the family pots usually contain a mixture of food ingredients, example, the family are having boiled fish with cabbage and tomatoes. Before you add salt to your meal as parents, just take a little amount and put it for the child before you put salt or sugar. And then you can put salt for your food. So let the child have part of your mixed food before putting salt, and then put salt to your food and eat together. Message number 8, a growing child needs increasing amount of food. So as we said, introduce food one at a time. This is very important. So the child gets accustomed to the new texture and taste. Mixed ingredients meals should only be given when the child is used to a variety of food. So don't mix until he's used to the variety of food, then you can mix it. Begin with soft mashed porridge, then add well-cooked mashed or strained vegetables, and finally add meat and fish as the child grows. Find out what is equivalent to 250 ml cup to guide you on the quantities to give to suit the child age. Increase the amount gradually as the child grows. Offer snacks between meals so they do not replace main meals. Message number 9, young child needs to learn to eat, encourage, and give help with lots of patience. Feeding time period is a period of learning and period of love. Children may eat better if feeding time are happy and enjoyable. Have regular meals times where the child can focus without distraction. So don't open TV or put video games or anything during meals. Respond positively to the child with a smile, eye contact, and encouraging words. Try different food combinations, tastes, and textures to encourage eating. Last message, encourage children to drink and eat during illness and provide extra food after illness to help them recover quickly. Most mothers, they think if the child is sick, they will avoid giving him food because he's sick. This is not true. Well-fed children recover quickly from illness. So during sickness, the child needs more energy and more nutrients to fight the infection, assist recovery, and support catch-up growth. A sick child often needs extra drinks, extra food during illness. For example, if they have fever or diarrhea, then you have to replace it by extra fluid and extra food. If the child does not get extra food, his or her fat and muscles tissue is used as a fuel. This is why they lose weight and become undernourished, look thin, and stop growing. So please, the message here, the sicker the child, the more he needs fluid and he needs food support. Encourage the sick child to continue eating even if she does not feel well. Add a teaspoon of margarine, coconut cream, cooking oil in the child plate of food to increase energy content. Then I will move to the last part, which is my subspecialty, which is called follow-up care of preterm and sick newborns. This is best achieved by standard early intervention programs to early detect any deviation from normal growth and development of infants, and hence start early intervention to prevent or minimize future handicap. So as the Dr. Summer mentioned, that I'm doing that since for the last 25 years, still going on at King Khalid University Hospital, which is called Neonatal Follow-up Program, aiming to establish a proper system to follow up high-risk cases, because unfortunately, everybody is concentrating on normal, healthy children and newborn, forgetting a major part of our community, which are the sick newborns. I don't say preterms only, I'm saying sick newborns, which could be also full term. So this program is aiming to help and support these tiny and sick newborns. We are aiming to perform neurodevelopmental evaluation to all high-risk infants graduated from our NICU. We start early intervention if needed, like rehabilitation, for example. We can start from NICU to prevent or avoid or minimize future handicap. We support parents from birth until after discharge. I follow them until the age of 2 years, and sometimes I follow them until the age of 7 years. It is a good tool for future research, especially if there are fellows with us tonight. And in ICU evaluation. By this program, I'm always looking at morbidities and doing statistics every 3 months to see our rates in different morbidities like retinopathy prematurity, bronchopulmonary dysplasia, sepsis, and so on. And then I'll go back to my colleagues in ICU and I'll tell them, listen, I noticed that there is increased rate of morbidities. So there is something wrong in your in ICU. So we need to be evaluated and change your practice to the best. This is example of the patients I'm seeing in my clinics. So if you can notice, many of them are not preterm babies. This is called high-risk list. I see patients or babies who were born 1,500 gram or less, mainly preterm, but sometimes I have IUGR babies. If 5-minute Apgar score less than 5, neonatal seizure, CNS abnormality, intraventricular hemorrhage, meningitis, congenital infections and syndromes, PBHN, persistent pulmonary hypertension, severe hypoxic event, diaphragmatic hernia, BBD, hyperbilirubinemia, and IUGR. So any patient with this risk, or if there is no risk factor, but I saw him in my clinics at the age of 2 months, and they noticed something abnormal, then he need to be evaluated neurodevelopmentally. Or if there is no risk and I have no problem, but the mother has concern, we have to respect the concern of the mother and take the baby for neurodevelopmental evaluation clinics, which is includes history, and we concentrate only on developmental history because this is sub-special clinic. Only developmental history, looking for the milestones. Physical examination concentrating on the muscle tone, upper and lower limbs, head, leg, control, sitting, crawling, creeping, all the physical exam related to development. Relevant investigations, which means something relevant to have a future handicap like vision and hearing. So we have to have investigations to make sure the baby can see well and can hear well. Then at the end, I will do developmental testing, which I will not discuss in this lecture because it needs a lecture alone. At the end, I am looking at the long-term outcome and report it as blindness, deafness, cerebral palsy, mental retardation. As neonatologists, we say the baby has intact survival if he does not have blindness, deafness, cerebral palsy, or mental retardation. So this is what we are trying to prevent, avoid, or at least minimize in the future by early detection and hence early intervention to have as normal as possible babies in the future. That concludes my lecture. Thank you very much.
Thank you very much, Professor Sabeh, for
Thank you.
addressing this very interesting topic.
Shukran.
I'm gonna take a look at the Q&As. So I do see one question in the chat, and the question says, what about mothers who report difficulty in breastfeeding or finding the baby doesn't get enough?
Okay. This is part of Baby Friendly Hospital Initiative, which I did not mention, but you find it in one of the 10 steps. In that case, a certified nurse or a doctor will sit with the mother, take full history, and see what is the problem. Is it a structural problem, for example, with the nipples, with the breast, engorged breast, inflammation? Is it positioning of the child? Is it latching? And there are so many issues that can be discussed, and there is a solution for each one of them. So such mother, she should go to a certified lactation consultant clinics. I think we have it now in every hospitals or even healthcare centers. She goes to a professional who is certified, and then he can take the full history to discover what is the problem and hence start intervention to succeed, to have successful breastfeeding.
Dr. Badr, Professor Badr, sorry, I know you haven't talked about much about the like the not the focus of the presentation is the baby-friendly hospital, but if I may ask you this question, when your points, the 10 key points that you mentioned of the initiative are very insightful, but many institutes they aspire to achieve this, yet there are so many struggles in the implementation process. So from your experience, what are the most significant challenges and how can the healthcare teams realistically overcome these challenges?
The most challenging part, because I started this in King Khalid University Hospital in 2016. I was the one in charge for Baby Friendly Hospital Initiative, but I failed. The reason for failure is from ourselves, the healthcare providers, professionals. I struggled because, as you know, you have to train 80% of nurses and doctors. We managed to train 80% of in-ICU doctors, OB-GYN doctors, and all nurses in the hospital. The challenge is with the administrative support because you have to train administrative people, assistant services. We failed to do that, and there was no support from the administration. That's why they're making it more mandatory now and very strict. And do you know that it is more difficult to have accreditation for a baby-friendly hospital, more difficult than the Canadian accreditation, more difficult than CBAHI. So the problem we are facing is within our facilities among healthcare providers because the awareness is not there. And this is, I think, step number 2 is to increase the awareness between the healthcare providers. Before that, you should have the policy which is adopted from WHO. The other steps are very easy. The most difficult is step number 1 and step number 2, and these are challenging. So we are struggling in our hospital. I know there are some centers. I don't know about military, but I think you succeeded already. I'm not sure. But I know King Faisal and many Minister of Health, they are already certified and they overcome these problems and struggles.
Yeah, it seems like it's just because the child's early life is spent mostly outside the hospital, so probably a way for us to figure out as the healthcare workers how we can extend these principles outside to the community may actually make a difference. We do all struggle with the initiation of the baby-friendly hospital and the consistency. It's like an overspread. I do see another question in the chat, and it says, in case of failure to thrive, how do you reintroduce nutrition, especially when the mother is not bonding with the kid? Interesting.
Yeah, this is a difficult issue, but we face it in reality. That's why I said you start bonding from the beginning before conception, because the earlier you start bonding, the best is the result. I think, Dr. Samar, you know that because you are a neonatologist, sometimes we face in our unit scenario of a child who's a newborn who stay with us for 1 year or even more, neglected by the parents, especially the mother. There's no bonding. So once the baby is discharged, there's no bonding between them, and there is malnourishment, failure to thrive, developmental deterioration. The key point here is bonding. We should sit with the mother, and we should not blame the mothers all the time that she's neglecting her child. First, she needs to sit with a professional, a counselor, to know what is the issue. Because maybe she has a stressful situations, she has no social support, she have no family support. So my answer is focus on the mother, see what is the underlying issue. If everything is okay and the mother is doing her best, but there's a problem with the child, then look for genetic problems, genetic disorders, something which was not discovered early in life. This is the approach. But first, start with proper history and investigation from the mother side, and then you can proceed according to your results. I hope I answered the question.
I think it's also, if you agree with me, it's just the establishment of our ICUs is not really much baby friendly from the beginnings. It doesn't really support the kangaroo care unless because we don't have the facility to give the mothers the privacy they need. And a lot of our patients, and I know the same issues you guys face in King Khalid, a lot of our mothers and families, they don't actually live in Riyadh. So that's a bit challenging to establish that bonding from the early on. There is
Yeah,
another question. Yeah,
mm,
sorry, go
that's
ahead.
why there is a approach internationally for what is called single family room in the ICU. In our expansion, we're trying to get this single family room. So the mother will stay with her child in one room, single. Even the father can come and they can sleep in that room. So that's an issue. But because of the our social issues, the mother cannot do kangaroo care, cannot expose in
Yeah,
front of everybody. There's no privacy.
yeah,
But at least you can do skin to skin contact by hand when the mother comes until we solve this problem. Go ahead.
inshallah. Another question. It says, how can we minimize complications for extreme premature babies? This is a tough question.
Yeah, it is tough, but the solution is very easy. To have an organized unit by having what is called problem list. Problem list. This is what we are doing in King Khalid Hospital because this is academic place for the last decades. We have a problem list. First, we start with counseling as much as possible before delivery. If we know that there is a preterm delivery ongoing, we go to the mother, talk to her, and sometimes we have booklet in Arabic to introduce what is preterm baby, what you expect to see in the ICU. Then after that, every round is bedside round, and we have checklist from CNS until the TOS. So the resident will present problem by problem to discuss each problem and have a solution for it. Our aim at the end is to minimize the high risk factors, which we know, like ROB, we can prevent by oxygen control, not to have saturation 100%, as well as BPD, gentle ventilation, infection by hygiene, and other, for example, neck by avoiding artificial milk and give breast milk from the beginning. Try to minimize medications and overuse of antibiotics unnecessarily. By this way, you can help in minimizing the morbidities and hence reducing the likelihood of having future neurodevelopmental delay.
Another question I see in the chat, Professor, it says in hot countries, and when the baby is kept outdoor, is there still a need to give babies water before the age of 6 months?
Not necessarily, because as you know, milk is fluid. 80% to 90% of it is water. That's a wrong conception from before. Even our grandmothers, they used to say that, give him water. The milk itself is 80 to 90% includes water. And once you start introduction of solids at the age of 6 months, if you remember one of the slides, I said give you a stable corb, which is اللي هو المحاصيل المحلية. And your local products like mangoes, orange, and so on in your local area that contains a lot of fluids and minerals. But this is after the age of 6 months. Initially, no, unless the mother has an issue. We did not talk about that. If the mother has medical issue or she tried really to have exclusive breast milk, but she failed, in that way, we can support her by other methods like even artificial milk, which we don't encourage, but nutrition is very important. If the mother cannot provide exclusive breast milk أو في الاسترضاع اللي هو I don't know in English يعني having another one to help to give breast milk, and this is known in donor milk. But definitely I will not start water.
Yeah, absolutely agree with you. Yeah, I do see repeated questions about the feed, but you just have answered these questions about what to feed in the first 5 to 6 months. I do have another question, Professor. So we all know you have been a pioneer in establishing, mashallah, the neonatal follow-up program in Saudi Arabia, which is really remarkable. But what do you see is the main barrier to scaling this structured follow-up program to a nationwide? I know that a lot of us are interested in establishing the similar setup that you have. So how can we ensure the sustainability of this with especially let me focus because I saw one question in the comment that talks about, actually the comment says, it's not a question, it's more of a comment. It's really helpful and I am thrilled to be here today. In a resource limited condition, I see that stressful situation came from mostly financial point of view. So in a resource limited hospital, what do you think are the points or the tricks they can take to establish such a program, even if it's on a small prospect?
First of all, I disagree that it is financial problem. It is not financial, it is administrative problem. Because you know what is the cost of neonatal follow-up program? How many reals? 0 real. It's only you, if you are interested and you are certified and you have proper training, you can do it. I'm doing it alone, by the way, 25 years. I am the only consultant around, I don't know if in Saudi Arabia as a whole, as a neonatologist, I mean, who's doing this alone. I have no support from administration. I have no financial support, but yet I've seen 1,600 babies or so on. Many of them graduated. Some of them are university graduates. Some of them are pioneers, and they're visiting us from time to time. So the neonatal follow-up program, to be honest, the idea itself is very simple. It is not costly. The problem with your institute, with your hospital, because there is no awareness. The only people aware are us, neonatology consultants even, neonatologists, and we are few in the country. But many of the fellows I trained from other hospitals, they're very interested. After graduation, they went back to their hospitals, but the administration refused to provide them with the clinic, with the nurses, with the support, which is rehabilitation support, which is already available in your hospital. So the issue to overcome this issue is you have to fight for it, even if alone, have a proper training. If you have your own clinic, even if you are a pediatrician, by American law, every time the child comes to pediatric clinic, general pediatric, he must have developmental evaluation by any method, which is mandatory. And the doctors who are not doing this will be sued in the court. So you can do it if you have a private clinic. Learn any of the tests, which are hundreds there. For example, I'm doing a Bailey screener, which takes 10 minutes only. It's a bag, you buy it, maybe 400 real. Get a training certificate, which is very simple, and then do it in your own clinic. Don't wait for others to support you, because the key point for successful prevention is detection.
True.
If you don't have tools, at least by developmental history, which is mandatory for all pediatricians, take a proper developmental history every time the child comes to you, follow his growth chart, and then if you detect any problem, try to help. Number one support and intervention is rehabilitation, mainly physiotherapy. Physiotherapy alone can prevent a lot of handicap in the future, especially in preterm babies. So this is the neonatal follow-up program. If you want, in general, in pediatrics, the best way to overcome this problem and have a normal future children is to have what is called family pediatrician, which is available in America, Canada, and many European countries, in which every child who's born, at the night or the day he was born, they assign him to the on-call pediatrician, and he will stay with him, following him until the age of 18 years. If you don't have this, you can have periodic check each time he comes to your clinic, even if you are a subspecialist like cardiologist or so on. You must check the child who comes to you by developmental history in order to detect any problem, and you can refer him to subspecialty. I hope I answered the question.
Yes, beautifully. There is another question in here, and I think maybe we're squeezed out of time, so maybe two more, three questions. It says, do we have to be trained as lactation consultants? And if not, what sort of training do we need to have?
No, lactation consultant is extremely difficult subspecialty. For me, for example, I'm not a lactation consultant, I'm a lactation lecturer. Lactation consultant, it have a very long course, 40 hours, in 40 hours, then you have to take this and that, a lot of things. But you need to be certified baby-friendly hospital initiative. Can be a nurse, can be a doctor. This is 20 hours course. I used to give it in King Khalid. I'm not sure if other hospitals still doing it or not. We receive candidate from outside, doctors and nurses. They came 2016 to be trained with us. It's very simple. You just attend 2 days. It is squeezed, by the way, to 2 days. It used to be 1 week. 2 days from 8 to 4. Attend the training, and then you'll be certified 20 hours. If you are certified, it means that you can talk to the mother, not to be lactation consultant, but certification by this program entitled you as a nurse or a doctor to talk to the mother about breastfeeding. If you are not having this certificate, it is not advisable to talk to the mother and counsel her about breastfeeding. Refer her at least to obstetrician, lactation consultant, or somebody who had this certificate 20 hours. It is still going on, but I don't know which hospital are doing it now.
That would be really interesting to know which places. I believe a lot of people who work in the pediatric field, especially neonatology, would be interested to have it. I think we have the last like few minutes in here. So I don't see any more questions, but let me say this. Let me ask you this question, Professor.
Okay.
You really ended your presentation with a very hopeful vision for a safer tomorrow, which is really inspiring. So if you could If you could prioritize just one area, whether it's clinical, educational, policy related, any area, what would you choose as the most important one to as a cornerstone for building that safe future for our children?
I would concentrate on education of the healthcare providers to increase their awareness about safer tomorrow for our children. Because if they are not educated, I'm talking about doctors, nurses, and anybody who's working with children or with pregnant ladies, if you don't have awareness, you don't have proper education, you don't have certificates like baby-friendly hospitals, you cannot support or help children and their family because you don't have the knowledge, you don't have the training. So I'll put my money on training our healthcare providers, whether in our center, in a private, in dispensaries. This is the cornerstone of having a bright future for children. If you do this, I think the others are very simple because the mothers and the family actually they are seeking support. They are shopping from one hospital to another, from one dispensary to the other, because they did not find somebody to sit with them and talk with them and explain to them. Every place you go, they give medications. They don't even take history, just give 4 to 5 medications. Baby's not improving. He goes to another hospital. They want somebody to talk to them. Nobody's taking history, except if you are in a big hospital or university hospital, then it is mandatory to take full history. So this is what I suggest, let us invest in our healthcare providers, increasing their awareness, training, certification.
Thank you very much, Professor Badr.
Thank you very much.
For this time presentation. We really appreciate
Shukran.
the knowledge you shared with us today and the experience.
Thank you very much.
So overall, on behalf of the Saudi Patient Safety Center, we extend our sincere thanks to Professor Badr Sabeh for his valuable presentation and to all the participants for their active engagement. And as part of our ongoing commitment to bringing you timely topics and distinguished speakers, we kindly ask you to complete the evaluation survey that will be shared at the end. Thank you once again, everyone, for joining us, and we look forward to welcome you in our upcoming webinars. Have a good day.
Thank you, Dr. Samar, and thank everyone who attended this lecture. Thank you.